This 3D diagram shows the lower right abdomen, focusing on a small dead-end tube called the appendix. On a normal day, it has no major digestive function, but if something blocks it, this tiny structure becomes a high-pressure trap. Notice its exact position right here in the lower right side, attached directly to the base of the large intestine. The trouble starts with a physical obstruction. In adults, this is usually a hard piece of stool called a fecalith, lodged firmly into the opening. In children, it is often caused by swollen lymph tissue. Because it is a dead-end tube, that single blockage traps all normal secretions inside. What was a quiet, benign organ is now a closed-loop system heading straight for mechanical failure. Looking at this cross-section of the blocked appendix, you can see what happens next. The trapped fluids have nowhere to go, causing the internal pressure to steadily rise and stretch the walls outward. This rising pressure eventually exceeds the pressure in the small blood vessels supplying the organ. This chokes off the blood flow, a state called ischemia, leaving the tissue oxygen-deprived and severely damaged. Without a healthy blood supply to defend the tissue, the native intestinal bacteria trapped inside seize the opportunity. They begin to multiply rapidly, spreading through the oxygen-starved space. The body responds to this bacterial invasion with massive inflammation. The appendix swells, throbs, and irritates the tissue immediately surrounding it. This rapid escalation from a physical block to a severe bacterial infection dictates the medical urgency. The pressure and infection will continue to build until the dying tissue ultimately ruptures. This diagram of the body's nerve pathways explains why a patient's pain rarely starts directly over the appendix itself. Early on, the pain is vague and centers around the belly button. This happens because the internal organs send distress signals through shared nerve pathways that map to the central abdomen. As the inflammation worsens, it physically touches the outer lining of the abdominal cavity. When this outer layer, the parietal peritoneum, becomes inflamed, the pain shifts sharply from the center to a highly localized point in the lower right side. However, anatomy varies. If a patient has a retrocecal appendix, meaning it sits behind the large intestine, that severe pain will instead show up in their flank or back. Or, if the appendix dips low into the pelvis, the swelling rubs directly against the bladder or lower bowel. This can trigger atypical symptoms like urinary discomfort or an increase in bowel movements that mimic diarrhea. To accurately diagnose appendicitis, doctors have to match the patient's specific pain location to the stage of the infection and their unique anatomical layout. To verify that the abdominal lining is inflamed, doctors carefully press on different areas of the stomach during a physical exam. One specific test looks for Rofsing sign. In this diagram, you can see that pressing firmly on the left side of the abdomen pushes internal pressure across the cavity. If the right side is inflamed, that pressure wave will trigger a sharp pain on the right. Another indicator is Dunphy sign. Asking the patient to simply cough forces the abdominal muscles to contract rapidly, grinding against the inflamed appendix and worsening the localized pain. Take a second to test yourself. If a patient's pain recently migrated and they flinch on the right side when you press on the left, what is the clinical name for that sign, and what specific tissue layer is inflamed? That's Rofsing sign, indicating inflammation of the parietal peritoneum. Doctors quantify the risk of appendicitis using a clinical scoring system. Here, we see how symptoms like pain migration and nausea are combined with physical signs and white blood cell counts to reach a final score. By pooling these specific exam techniques and laboratory data, doctors turn a patient's subjective experience and physical reactions into a calculated probability of infection. Once the diagnosis is confirmed, treatment depends entirely on severity, as shown in this decision tree. The top path represents an uncomplicated case. The appendix is inflamed but intact, so the immediate solution is surgical removal combined with antibiotics. But if the condition goes untreated and the appendix ruptures or forms an enclosed abscess, the case becomes complicated. As the bottom path shows, performing surgery immediately in a highly inflamed, ruptured environment is often too risky. Instead, doctors place a drainage tube and administer strong IV antibiotics to control the spread of infection inside the abdomen. The surgery is delayed until the area is completely stabilized. Reviewing the flowchart, the full progression is clear. A physical blockage creates rising pressure, causing ischemia. Bacteria multiply, leading to severe inflammation. The pain migrates from a vague central ache to a localized, sharp point, dictating the necessary treatment path. Tracking the migration of pain and its specific location allows for an intervention in the blockage cascade before it transforms from a surgical fix into a life-threatening abdominal emergency.